Assalamu alaikum. Thank you, Dr. Sami, and thank you for organizing the committee for inviting me today. I will talk about management of pain, cancer pain at home, and I will focus on home care in general and palliative care. Okay. Now, question for everybody, volunteer. Suppose that you have your relative, father, or your mother, and etc., has a cancer. Who would like his relative to spend less time in hospital, and who would like her or him to stay at home? Any volunteer? Huh? Home or hospital? First, who like home? طيب. Who would like hospital? Oh, nobody. Oh, one. Why you think the hospital better than home?
I think that staying at the hospital is less dramatic for the cancer patient.
Okay.
That's why, God forbid, if I were a cancer patient, I think I would prefer to be.
Let me ask a specific question. Do you think you can control symptom at hospital better than home?
I'm not a medical doctor, so I can't answer this. I'm
Just
a psychologist.
give me your estimation.
If you ask me about the psychological factor, I think the hospital is better,
Yeah.
less dramatic.
Yeah, but I mean that's general term. But let's go specifically. Is it the symptom control better in hospital than home? Is it comfortable to the patient psychologically? That's very important for you. At home or hospital? So what do you think psychological part here?
If the cancer patient feels that he's at home, he will be more comfortable. I think the symptom control will be more at home.
Okay.
Otherwise, I think the hospital is the choice.
Okay. Who with home want to talk? Give us advantage. But a lot of ladies they want to, but here so okay.
ممكن
Just let him talk. Yeah, go ahead.
اسمحوا لي اتكلم باللغه العربيه.
تفضل. لا
دكتور
تفضل.
عبد الله شقير من الرعايه المنزليه.
ايوه خلاص انت
تجربة
وصلنا خير.
طبعا المركز الرئيسي للمملكه بالمدينه.
ما شاء الله.
فلان تجربه كبيره جدا بهالامر هذا. احنا بناخذ الامور بكافه جوانبها. انا يعذرني زميلي الطبيب على الوضع. احنا لين تجربه في المنزل بالنسبه للمريض كغالبيه اكثر المرضى بحد ذاتهم سواء كونشوس او انكونشوس اورينتد او نوت بالبيت بيشعر بالامان اكثر. واحد بيشعر انه عند اهله، بيشعر انه مخدوم منظف بشكل احسن.
ما في فيزيتنج اور. ما في سكيورتي يمنع المرضى وقارب يدخلون من الباب.
اي طلب حتى لو خفيف بيلاقيه في البيت. هذا بالنسبه للمريض، فبيشعر بكافه عوامل الامان، بيصلي مثل ما بده ومثل ما بده بجسم ما بده مع المرافقين. الشيء الاخر الكير جيفرز على الاطلاق كلياتهم، في منهم ايجابيين في منهم سلبيين مع المريض، لكن الغالبيه ايجابيين، فهو بيشعر بالحنان والعطف. وبالنسبه للمرضى البالياتيف كير اصلا احنا ايش بدنا نقدم لهم غير العوامل النفسيه تقريبا.
صحيح.
مع احترامي لزميلي، لو اخذنا 100 مريض انا من خلال المعطيات اللي عندي على ارض الواقع 99% و9 بالعشرة بدهم البيت، و0.1% بده المستشفى، لانه ظروف البيت غير
طيب.
مؤهله ولا باي.
ممتاز.
حتى لو كان بور بيبل، حتى لو كان ما عنده شيء ياكله في البيت بيشعر احسن.
طيب سؤالي لك ما دامت في الهوم كير.
تفضل.
كلامك صح، بس ليش most of our patients die in hospital spend less time in their life in hospital؟ ليش ما نحقق أمنية المريض اللي أنت قلتها 99.9 وكذا؟
المريض امنيته بالبيت.
ها؟
المريض امنيته بالبيت اكثر.
بس الواقع إنه أكثرهم يكون في المستشفى
بدك تسمح لي هون عاد.
ليش
ليش.
عندكم في وفيات في البيت كثير؟
لا الحمد لله الامور كويسه عم
لا أنا أقول الواقع إنه أكثر المرضى يموتوا في المستشفى.
يموتوا
يموتوا في المستشفى،
هذا ايضا نفس العوامل،
او يجلس اخر ايامه في المستشفى ما يكون في البيت.
هاي العوامل.
ليش؟ هذا سؤالي.
لانه المريض اصلا مثل ما قلنا اذا كونشوس اورينتد او نوت بيشعر بالامان بالبيت اكثر من المستشفى. بالمستشفى في عوامل كثيره بتخليه انه يكون البيت اكثر.
شكرا. بس ليش هذا مو الواقع؟ ليش؟
انا اقول لك شغله، طبعا مع احترامي عدل الوضع، احنا هون في المملكه
ايوه
يختلف، يعني زرت دول كثيره عربيه وغير عربيه.
ايوه.
هون الظروف وزاره الصحه يعني بكل شيء مؤهب بالمستشفى، طلبوا بلسانه اي شيء بده اياه، اي طبيب اي شغله اي استشاره بلاقيها في المستشفى، لذلك بده المستشفى. انا هذا من تجربه على ارض الواقع انا بتكلم. صحيح.
طبعا ناخذ I will talk about all these issues in the لكن I think there is
سبب يا عبد الله.
تفضل.
المريض عاوز البيت، بس اللي بيخليه يجي المستشفى الفاميلي. يعني why they are dying at hospital not because of their wish to die at the hospital. The family impose that on them. They bring them to the hospital.
I think دكتور I had just comment. الفاميلي if they found there is service good service at home، أول حاجة إنه في service. الشيء الثاني إنه simple access to the physician through phone through any way. they choose to stay at home. هذه من تجربة. لكن المشكلة المريض يخشى إنه يطلع من المستشفى وبعدين يصير أي حاجة acute crisis حيدخل في دايلمة، لأنه لو راح الإسعاف ما حياخذه، وإذا شالوه في السيارة ودوه للER حيقعد 2 days in the ER no bed، وفلما يدخل في المستشفى خلاص ما وده يطلع. فstay in hospital until he die. لكن if solve this problem حيكون عندك good home care، visit the patient twice a week 3 times a week، change medication، يعطيك كل حاجة، access to the hospital. خلاص احنا طبعا من تجربة ودنا هالتجربة تتكرر في المدينة وتتكرر في حائل، انه عندنا الهوت لاين وعندنا simple access for those kind of patient. اذا كلمنا المريض واحتاج انه يدخل ما يمر حتى على الإيار، سيارة الإسعاف من المستشفى تروح البيت في ظرف بس مشوار ويكون البيد available in the hospital. إذا هذا موجود everybody نحقق أمنية المريض. طيب during my presentation I'm gonna talk about the principle palliative care evidence. That's very important part of the presentation. The evidence that support home care over usual care. And last I'm going to talk about patient control analgesia, the bomb that Dr. Foda mentioned in his presentation. That's WHO definition of palliative care. Palliative care is the comprehensive management of patient physical, psychological, social, spiritual, and existential needs, especially suited to care of people with incurable progressive illnesses. And that's just to told you there is 2 models to palliative care. There is old model and new models. The old model is that's the palliative care service start after diagnosis of incurable disease. It's not only cancer. Cancer could be HIV, could be liver cirrhosis, could be end-stage heart disease. All those is incurable disease. Once diagnosed, the primary physician will take care after, and he give anything possible to prolong survive. After all this intervention failed, he gonna refer him or transfer him to palliative care or hospice. Okay? Then the relation end up at die. Once the patient die, gonna go to the morgue and that's it. The new model that we encourage is yes, the beginning of relation with palliative care team start at diagnosis, but gonna be start at the day of diagnosis. However, still the patient maybe need chemotherapy, need surgery, need radiation therapy, and the role of palliative care minimal at the beginning, but over time the responsibility of palliative care increase and the responsibility of primary physician decrease until we reach the point that the patient gonna be 100% palliative. At that time, easy to the patient and family accepted the palliative care transfer. So we be confirmed that the patient will transfer early, not late, and the relation gonna be not only for patient, going to be for family as well, so the relation not end up with death. It's going to be extended to bereavement service. That's what we encourage here. The new model of palliative care, that once the patient diagnosed with incurable disease has to refer to palliative care to be seen as early as possible, not after everything done for the patient, transfer to palliative care. However, there is many advantage over the second model. One of the basic palliative care is to discuss the option with the patient, either chemo or radiation, etc. For example, if the patient have lung cancer, we know that metastatic lung cancer, the prognosis 6 months. The chemotherapy may be prolonged survival for 3 months. So is it worthwhile to take chemotherapy or not? So you have to discuss that with the patient, okay? This is very critical, easy to discuss it if involve palliative care as early as possible. Because the oncologist always would like to give everything possible because they didn't want to feel guilty, so they give the chemotherapy, radiation, surgery, etc. But this is very critical. If the patient knows that the chemotherapy with all its complication only prolonged survival for 3 months, maybe choose not to take chemotherapy. And that's the important. That's why one study done in MD Anderson, I think, and published in New England Journal in 2010, compare between 2 hospitals. One hospital does not have palliative care, and the other hospital has palliative care. And the hospital that does not have, they compare between the same kind of disease, which is non-small lung cancer. So we know that non-small lung cancer has very poor prognosis. So the main objective is how much the symptom control and how much psychological complication improve. And we expected that those with has palliative care has better control, better quality of life, and decrease psychological problems. Is that true? The amazing thing that they found that even survival prolonged for 3 months. So this is not their objective, but they found that, and it's published. It's very significant to find that only palliative care support the patient with simple medication and support and etc. will prolong survival for 3 months. So palliative care is not only improve quality of life and decrease symptoms, but could be even prolong survival. So that's why we encourage the new model, transfer patient early as possible, involve palliative care as early as possible, and has to have the service covering all over the kingdom. Okay, so to do a proper palliative care, you have to have inpatient, outpatient, 24/7 hotline to answer the question for those kind of patients, and home care. All this kind of service to work together to serve our patients. So home care, the patient-centered medical home, is a healthcare setting that facilitated partnership between individual patient and their personal physician and family. So we not only support the patient, also we support the family. So usually home care assists the symptom, medication, do physical exam, patient understand the extent of the disease, and the important thing is we have to discuss the patient agenda, what the patient wants from us. So we have to know what his goal is. Is it symptom control? As the Egyptian guy want to attend his graduate of his daughter, etc. Home physical arrangement and DNR status. Okay. That's usually we use ESAS, which is 10 common symptoms. I don't know if you are familiar with ESAS. ESAS is the questionnaire. Has 10 symptoms, which is pain, shortness of breath, tiredness, fatigue, and those 10 common symptoms in cancer patient. So for every symptom, we have 0 to 10 scale, and we're gonna ask the patient to answer he has pain or not. If he has pain, how much out of 10? Just to screen all his physical symptoms and psychological, because there is depression and anxiety questionnaire. Hydration status, home care equipment, what he needs. Sometimes he needs medical bed, commode, wheelchair, etc. Or assessment. Okay. Now came to the evidence. I want to discuss with you because you are mentioned those points. Here, study done in UK, okay, and they ask patient where you want to die. Simple question that ask everybody, and most of them, less than 60%, want to die at home. But the reality that's maybe half of them die at home and majority die in hospital. So that's not only in Saudi Arabia, even in UK they have proper home care. Sometimes we fail because a lot of problem. So why, if that's my target from this presentation, we have to make our service ready to make patient wishes. If the patient wish to die at home, we have to do proper home care facility and easy accessibility to the hospital if he needs. Okay? Okay. People who have palliative home care people want to be cared for at home, have need which can be met by the program, have the home where can provide it, have doctor. Okay, that's however, every home care has his criteria. I know that home care need to have somebody at home, isn't it, from the family, and some of them ask for 2 home care, health care, 2-member family at home to support the family, support the patient. Is that true? أنت تطلب 2 صح؟ ولا 1 enough؟ يعني okay. May choose to die at home. Okay, that's the study done in Italy. Patient home care reduced time spent in hospital ward, population-based study. The method is retrospective analysis, included 3,423 cancer patients, and 9% of them receive palliative home care. The majority, more than 91%, does not receive. Palliative home care was effective in reducing the utilization of hospital care during the last 3 months of life. 25% reduction in admission, which is very significant. Maybe I'm going to show you here. 49 reduction in spending day in hospital. Home care will decrease the after length of stay in hospital, decrease readmission to the hospital, decrease ER visit, and decrease ICU admission. So all this save money and save bed for other patients who need it more than them. So home care is not something, is mandatory for cancer patient. Okay, and that's the result of the study. Death in hospital for they compare between area has palliative care and the area does not have palliative care. Okay, they found that area that has palliative care 16.4 who actually die in hospital, while 41% in the area that does not have palliative care. Median length of stay 3 days for area has home health care, and 12 days for area does not have home health care. Imagine how many days we save and how many beds available for other patients. Average cost, actually, we save in this study up to 30% of the cost of admission, readmission, ER visit, ICU, etc. Also symptom, who is not only controlling, saving money, saving bed. The symptom control actually better in area has home health care comparing to area does not have palliative care. And significant on pain, significant on nausea, significant in most of the symptom. So the palliative home care has very superiority over the area that does not have palliative care. Not only that, the family also satisfied with the care. This randomized control trial done for 298 terminally ill patients with prognosis less than 1 year, and the intervention was usual care without palliative care and palliative care service, and the outcome was satisfaction and cost. And see here, satisfaction increase up to 93% in area has palliative care, comparing to 74% in area not have palliative care. Also the cost, more than half here, the cost 95 and here 200. So up to half or more than half save money. So the palliative care will save money, increase satisfaction, and improve symptom control and psychological control. So why didn't apply it? Why didn't have service in Medina? That's the time that we have to start to have this service. If we have medication costs 10 million riyal and told you that medication will increase satisfaction, control the symptoms, save money, you're going to spend that, isn't it? But for service like this, easy, accessible, I don't know why we delay, not started yet in Medina or Hail or anywhere. The service only available in Riyadh, Jeddah, and Dammam. Okay, and this other study showing that palliative care save money. Okay, that's the only answering some of your question. That actually study shows that very effective intervention will save money, improve symptom. You are right that still, if the patient discharged home and he didn't have simple accessible to hospital, accessible way to go back to hospital, he will not go home. And that's what happened to majority of our patients. Stay in hospital until death. Okay, now just talking about to do home care, proper palliative home health care, you have to have some facilities. The most important is BCA, a continuous ambulatory delivery device, which is simple machine, just put it here, and can deliver not only morphine, actually sometimes antibiotics. We can give flurazepam, etc. Any medication the patient is unable to swallow, unable to eat, the pump can control those symptoms. So there's many names, either CAT or BCA, which is patient control analgesia. It's portable, simple. We need to have sub-Q access through butterfly. You have butterfly needle. The butterfly needle is sub-Q injection and gonna stay in place and hooked to the BCA machine and can deliver the medication over 24 hours, every hour. Okay, so indication for severe nausea, inadequate GI absorption, and ability to tolerate oral medication and control pain. So, for example, we have this patient, 50-year-old male with nasopharyngeal cancer and difficulty swallowing with recurrent vomiting. He has experienced 7 out of 10 stabbing left facial pain. He on morphine 50 milligram Q4 hour and 25 every 1 hour BRN, and using 4 breakthroughs in the last 24 hours. So what the best way to do for this patient who is unable to swallow, to change him to bump. Okay, so that's example of the bump. I've seen very nice bump with Dr. Foda presentation, small, smaller than this and more practical, but that example of the bump, simple machine hooked to the cassette. The cassette has a key, so only one has right to change it is the home health care nurse. And they can program it. So maybe you needed to change the cassette every 1 week or 2 weeks. The home health care came to the patient, open the key, change the cassette, reprogram it, and go. The patient, family, unable to change the programming. So the medication gonna be delivered to 24 hour. Okay, so this part of the presentation need actually more practical workshop or something. How we calculate, how we make the medication. We have to write the order about the drug, the concentration, dose, breakthrough volume. So, for example, you have to write concentration morphine 20 milligram per ml, cassette 100 ml, rate 8 milligram per hour sub-Q continuous infusion, and demanding dose gonna be 4 hour, because all this programming, all this information need to filled up in the program. Okay, depend on your concentration. After that, you can make the machine work. Just give you a summary how important home health care. is very core, important service in palliative care. You cannot have very good care for cancer patient without proper home care. Thank you.
Thank you very much, Dr. Abdullah, for this presentation.